Imagine walking into a hospital where every smile, every word, and every gesture honors who you are and where you came from. That's the vision behind the Purnell model of cultural competence. Good day, everyone. We are the Group 3 BSN 4C, and today we'll show you how this model transforms nursing from simple care into a meaningful healing.
Cultural competence has become an essential concept in modern healthcare, especially with the growing diversity of patients worldwide. Health professionals are expected to provide care that respects patients' cultural values, beliefs, and practices. One widely used framework for understanding and practicing cultural competence is the Purnell model of cultural competence, developed by Dr. Larry Purnell in 1995. This model provides a comprehensive guide for assessing cultural attributes and applying them to patient centered care. It emphasizes the importance of recognizing cultural diversity and integrating patients' beliefs, values, and practices into healthcare delivery. The model is represented by a circle divided into 12 domains, which will be discussed later. And by using this model, nurses and other healthcare professionals can develop greater self awareness, avoid cultural misunderstandings, and provide holistic patient centered care that respects cultural differences and promotes positive health outcomes. The purpose of this report is to present a detailed overview of the model, its structure, the 12 cultural domains, and its application to healthcare practice. The report will also highlight the strengths, limitations, and relevance of the model in today's multicultural healthcare environments.
The Purnell model for cultural competence was developed by Larry D. Purnell and Betty J. Paulanca as a tool to encourage the importance of cultural awareness. It proposes that healthcare workers are bound to encounter patients with diverse backgrounds in their day-to-day life in the clinical settings. It provides a basis for healthcare workers to understand concepts and features such as language, values, beliefs, and customs relating to different cultures as a way to promote culturally competent healthcare. It consists of four circles of various sizes, each representing all the meta paradigms applied to nursing, and the inner circle consists of 12 cultural domains.
The Purnell model for cultural competence is a holistic framework used in nursing, healthcare, and other disciplines to provide culturally sensitive care. It is often depicted as a circle divided into 12 cultural domains representing interconnected aspects of culture. The circle symbolizes wholeness, completeness, and interconnection. Inside the circle are wedges, each representing a domain of culture. The outer rim represents the global society, the next is community, then family, and finally, the person at the center. This layering shows how individuals are influenced by broader context. At the very center lies the black circle, representing unknown phenomena, things about culture that cannot be known or are not yet discovered. This reminds practitioners to remain humble and open to learning.
Next is we're going to discuss about the 12 cultural domains. One is heritage. It is a country of origin, reasons for migration, current residence, education, and occupation. Examples are family, values of Filipino and Middle Eastern Islamic traditions. Next is communication. It is a language, dialects, voice patterns, nonverbal cues, and the use of interpreters. Examples are Japanese prefer silence and Americans prefer direct speech. Next is the family roles and organization. It is a family structure, decision making, authority, gender roles, and responsibilities of elders and children. Examples are Hispanic fathers as decision maker and Filipino mother in charge of health. Next is the workforce issues. It is the acculturation, autonomy, workplace stress, and professional interactions. Examples are migrant workers face language barriers, and some cultures restrict women from working. Next is biocultural ecology. These are the biological and genetic variations, skin color, physical differences, and disease prevalence. Examples are sickle cell anemia in African Americans and alcohol flushing in Asians. Next is the high risk behaviors. These are the use of alcohol, tobacco, drugs, unsafe sex, and extreme activities. Examples are Europeans drink socially and Muslims avoid alcohol.
Let's proceed with the nutrition. So these are the dietary habits, the food restrictions, the meaning of food, and the culturally specific diets. Examples are the Hindus who avoid the beef, the Muslims who avoid pork, which is the halal diet. And next, we have the pregnancy and childbearing practices. So this includes the fertility beliefs, the prenatal care, the birthing rituals, and the postpartum practices. And the examples are the Chinese who believe with the sitting of the month, the Western women who resume activities early, and let's proceed with the death rituals, which are the beliefs about death, the mourning practices, the body preparations, and the funeral customs. And examples are the Filipinos who do the novena and the Hindu who do the cremation. We have here next is the spirituality. So this includes the religious beliefs, prayer rituals, and the meaning of life. And the examples are the Muslims who pray 5 times daily and the Native Americans who use smudging. Next, we have the healthcare practices. This includes the health-seeking behaviors, self-care, the pain expression, and the illness preventions. And the examples are the Asians who follow yin-yang balance and the Western care who uses evidence-based treatment. And lastly, we have the healthcare practitioners. These are the perceptions of the doctors, the nurses, traditional healers, and the preferred care providers. And the examples are the Native Americans who consult the shamans, and the Muslim women who preferred female doctors also.
Now we have here the stages of cultural competence. First, we have the unconsciously incompetent. This is the lack of awareness of cultural differences. For example, a healthcare provider may expect all patients to make eye contact as a sign of honesty, overlooking that in some cultures, avoiding eye contact is a sign of respect. Next, we have the consciously incompetent. This is the awareness of cultural differences but lacking skills to respond appropriately. For example, a nurse might ask about a patient's dietary restrictions during hospitalization, but may not know how to adjust the care plan to meet those needs. Next is the consciously competent. This is the active effort to understand, adapt, and integrate cultural knowledge. At this stage, the person can apply cultural knowledge and skills deliberately in their practice. They actively make efforts to adapt, such as scheduling an interpreter for a patient with limited English proficiency, tailoring treatments to plan aligned with cultural differences, or involving family members in decision making when appropriate. Then lastly, we have the unconsciously competent. Cultural sensitivity becomes natural and automatic in practice. This is the highest stage where cultural sensitivity becomes second nature. The person can seamlessly anticipate and respond to cultural needs without deliberate effort.
Application in nursing and healthcare. The Purnell model for cultural competence is a holistic framework that helps nurses deliver culturally sensitive care. Nurses apply it across the nursing process to ensure care respects the patient's cultural values. Assessment helps nurses obtain a detailed cultural history and understand patient needs. Planning enables care plans that respect cultural values, traditions, and practices. Implementation guides interventions that build trust and patient cooperation. Evaluation provides criteria for evaluating the effectiveness of a culturally sensitive care. Assessment Communication nurses can assess preferred language, use of interpreters, eye contact, and nonverbal cues. For instance, a Spanish speaking patient may require a translator to avoid miscommunication. Family roles and organization identify decision makers, gender roles, and caregiving responsibilities. In many cultures, health decisions are made by elders, not the patient alone. Nutrition ask about food restrictions. One example is the Muslim diet, which is guided by the Islamic law, particularly the concepts of halal and haram. Health practices explore use of traditional remedies. Some cultures refer to the use of herbal medicine and spiritual healing.
Planning. Establish mutual goals that respect cultural preferences. For patient with specific death rituals like Catholic requesting last rites, nurses plan to coordinate with spiritual leaders.
Intervention communication. Use professional interpreters instead of family members to ensure accuracy and confidentiality. Healthcare practices. Integrate traditional healing like herbal teas as long as they do not interfere with prescribed treatments. Spirituality. Allow time for prayer or religious rituals before procedures. Lastly, death rituals. Respect mourning practices such as allowing extended family presence or specific rituals at the bedside.
So let's discuss the Purnell's model strengths, limitations, and criticisms. So under strength, first is holistic and comprehensive. The model looks at the patient as a whole, not just their disease. It considers physical, emotional, social, cultural, and spiritual factors. Next is practical application. The model can be directly used in real situations like nursing medicine, social work, and public health. Next is structured framework. The model is organized into domains within a circle, which makes it easier to follow systematically. And next is universal use. It is not limited to one culture or profession. It can be used across many settings and populations.
Next is supports self reflection. It encourages healthcare workers to examine their own cultural biases and beliefs and also values. And next is facilitates communication. It gives providers a guide for asking cultural sensitive questions that improve trust and relationships with patients. Lastly, adaptability. It can be used not just for individual patient care, but also for organizational training and even policy making. So, under limitations, first is complexity. With the 12 domains, the model can feel very overwhelming or time consuming, especially in busy clinical settings. Next is risk of oversimplification. Some may use it too rigidly, assuming all people from a culture are the same, leading to stereotyping. Next is limited empirical validation. It is widely used in education, but aren't many scientific studies proving it may improve patient outcomes. Next is cultural change not accounted for. It means cultures are dynamic and changing, but the model may not fully capture migration, mixed cultures, or evolving identities. Lastly, training requirement. To use it properly, healthcare workers need training. Without it, they may misuse or misunderstand the model. So, other criticisms. Firstly, it is too generalized. What does this mean? It gives broad categories but not always detailed guidance for specific cultural issues. Next is Western centric perspective. Some argue it reflects Western values, like individual autonomy, more than non Western or collectivist cultures. For example, in some Asian or Eastern cultures, the family decides about surgery, not the patient, but the model assumes individual choice. And next is potential for cultural essentialism. It may unintentionally make people view cultures as fixed sets of traits instead of diverse and evolving. Next is not always patient led. Um, the model focuses on the provider assessing the patient instead of letting the patient define their own cultural needs. And lastly, limited evidence of outcome improvement. While it raised awareness, it's unclear if it directly reduces health inequalities or improves patient health.
So we've reached the conclusion part for Purnell's model of nursing care. So Purnell developed a model for cultural competence in 1998, and it is used by nurses and other healthcare professionals to provide holistic and culturally competent care to patients of diverse backgrounds. Its main goal is to help healthcare providers understand the cultural influences on a patient's practices, beliefs, and health so that these healthcare providers can deliver care that is respectful, safe, and effective. The key features of this model is that this model is often shown as a circle or a wheel with 12 cultural domains inside of it. At the center is the person or the patient, and around this patient is the family, community, and society. So it shows that culture affects all aspects of life and all must be considered in nursing care. For the 12 domains of the Purnell model, so these areas are the areas that the nurse should assess when giving care. Number one is heritage, the patient's background, country of origin, and reasons for migration. Next is communication, the language, dialect, nonverbal cues, use of silence, and eye contact. And then third is the family roles and organizations, gender roles, decision making patterns, and the importance of elders. And then fourth is the workforce issues like employment, autonomy, acculturation, and assimilation. And then fifth one is the biocultural ecology like genetic factors, skin color, structure, common diseases, and the likes. And then the sixth one is high risk behaviors, so such as the use of tobacco, alcohol, drugs, and safety practices. And then we have nutrition, like food preferences, taboos, and meal patterns. The eighth one is pregnancy and childbearing practices, like fertility beliefs, birthing practices, and postpartum care. And then the ninth one is death rituals, like beliefs and practices about death, dying, and mourning. And then spirituality, like religious practices, prayers, meaning of life, and spiritual healing. And then the 11th one is the healthcare practices, like the perception of the client of illness. And then traditional healing, like the use of Western medicine. And then the last one is healthcare practitioners. What does the patient perceive of the different providers, like the nurses, doctors, shamans, and healers? Applications in nursing for this model is on four levels. the assessment, planning, implementation, and then lastly, the evaluation. For the assessment, nurses use the 12 domains to assess a patient's cultural background. And then next, they move on to planning, which care plans are made and then adjusted to respect cultural beliefs, such as diet, rituals, and decision makings. Implementation, nurses implement cultural sensitivity, like the use of interpreters, and then respecting gender roles. For evaluation, care is not evaluated medically, not only evaluated medically, but also culturally. So the main question here is, did the patient feel respected and understood? An example of the use of this model is that a Filipino patient prefers herbal remedies alongside prescribed medicine. So instead of dismissing it, the nurse assesses for safety and educates the patient about possible interactions, and then integrates it respectfully into the care plan. And in short, the Purnell model helps nurses see the whole patient through a cultural lens, leading to a more effective, empathetic, and patient centered care.
In today's story, three nurses encounter a patient whose cultural background shapes her health beliefs. They must apply the Purnell model of cultural competence to provide the best care.
Anna, I'm not sure how to talk to our new patient. She speaks very little English, and I think her family has strong cultural traditions.
That's okay, Bea. Remember, the first step is awareness. We must recognize that our patient's culture influences her health.
Yes, so let's try to communicate respectfully. Even a warm smile can build trust.
Good morning, Maria. We are your nurses today.
Good morning.
The nurses practice sensitivity, showing respect through tone, body language, and patience.
So, Maria, do you follow any special health practices or diet? We want to respect your preferences.
Yes, I drink herbal tea every morning for strength.
Thank you for sharing that, Maria. We will note it in your care plan so it doesn't create conflict with your other medicines.
See, we're exploring the domains of cultural competence, like health practices, communication, and family roles.
Okay, Maria, would you like your daughter to be involved when you explain your treatment?
Yes, please. Family important.
Sure, Maria. We'll arrange that. I guess in your culture, family plays a big role in decision making, and we respect that.
By recognizing Maria's values, the nurses practice culturally competent care, moving from awareness to skill and integration.
Today, I realized that cultural competence isn't just about knowledge. It's respect, listening, and adapting.
Exactly, Bea. When we honor our patient's culture, we don't just treat illness, we heal with compassion.
And that is the true heart of nursing.
Through the Purnell model of cultural competence, nurses Anne, Bea, and Carla learn to bridge differences, showing that care is stronger when rooted in understanding.